Hello, I am Dr. Mike Zaretsky, maternal fetal medicine specialist at the Colorado Fetal Care Center, and I'm here with Dr. Cristina Wood from anesthesia, and today we're going to be talking pain management after cesarean delivery. So Dr. Wood, how did we start with pain management after cesarean delivery?
So we were pretty standardized, as most labor and delivery units are. For our pain management, we do 95% or more spinal anesthetic or epidural anesthetics. We did pretty high-dose Duramorph, which is morphine that goes into either the intrathecal space or the epidural space. And that lasts for a good 24 hours for pain relief. But our doses were, like I said, pretty high. We didn't maximize our antiemetics, so we were using maybe 1 or 2 antiemetics per case. And when the patients were recovering, we certainly had them on as-needed medications that were non-opiates. So they weren't scheduled acetaminophen, they weren't scheduled NSAIDs. So the first pain medication that most people reached for then when they were in pain was an opiate medication. So we found that a lot of the inpatient medication use was opiate, which led to higher prescription use afterwards as well. We didn't get our patients out of bed as we should have, so typically bed rest was about 12 hours after the surgery. Their Foley catheters stayed in, and we wouldn't let them eat or drink anything until we really felt like that bowel function had returned. So there was a big delay in that.
What happened next with our pain management? We added a wound soaker after cesarean delivery. Tell us a little bit about that.
So I think we're all aware of the opiate crisis in this country. So we're always looking for ways to try to reduce that usage. And one of our obstetricians, Dr. Frank Chow, had used a wound soaker at another practice and thought that it might be something that could help with pain control that was non-opiate. So he brought it to the Colorado Fetal Care Center. All of our obstetricians and MFMs were trained on that. And we now place it routinely for all of our cesarean deliveries and our big fetal surgeries. One of the things that we found with that, when we looked back at the data from those that had a wound soaker and those that did not, is a 30% reduction in post-operative opiate use. We saw that in our cesarean deliveries and we saw that in our fetal surgeries, just by having a local anesthetic kind of numb the area where the incision was.
So tell us a little bit about what ERAC is, and how did that further improve our pain management after cesarean delivery?
Sure. So the Society for OB Anesthesia and Perinatology is kind of our governing body for a lot of guidelines for pain management, all things obstetrics. And in 2019, they published these Early Recovery After Cesarean, or ERAC guidelines. They divided them into 3 different segments, so pre-op, intra-op, and post-op. Pre-operatively, we now started giving our patients clears up to 2 hours before surgery, and carbohydrate clears, so Gatorades, apple juice, things that were really going to give them some sustenance before surgery. We also provided a patient education sheet that helped reduce some of that anxiety so patients had an idea of what to expect when they were coming in. Intraoperatively, we followed evidence-based dose-response curves for morphine. So we used much lower doses that just provided analgesia and minimized side effects, both intrathecally as well as epidurally. We minimized our fluids to less than 3 liters per case. And our obstetricians were very helpful as well in not irrigating the abdomen. That can create a lot of pain, trying not to externalize the uterus. We also kept our patients very warm, and we kept their blood pressures at baseline. Hypotension can just be create so much nausea in that operating room, which can also lead to difficulty with the surgery, can also lead to pain after the surgery. So we kept their blood pressure at a baseline level. We used the minimum amount of oxytocin needed, because that also can cause some hypotension or low blood pressures as well. And we moved up from 1 to 2 anti-nausea medications to 3 to 4 anti-nausea medications. Finally, post-operatively, we got them eating within an hour after their surgery, so at least starting on some water and some ice chips. And gum chewing was another thing that came out that really seemed to stimulate that bowel function, so we get all of our patients chewing gum right after surgery. We get them ambulating or at least out of bed the first 8 hours, their Foley catheter out, to really help them mobilize, and that actually helps with pain. I think one of the most important things is the scheduled non-opiate medications, though. So every 6 hours, they're getting acetaminophen and they're getting an NSAID. And we spaced out our vital signs to coincide with that, so our patients get nice 6-hour blocks of rest, which helps them recover as well. After doing that, we then looked at pre-ERAC implementation and post-ERAC, and we found an 80% further reduction in opiate use with the implementation of that.
Significant reduction.
So Mike, regarding the wound soakers, I know we're really interested to know how much they contribute now to our pain management and opiate reduction with the introduction of ERAC. So can you talk a little bit about how you're investigating that?
Yeah, with this data coming out showing this 80% reduction in opioid use, the question now remains, how much does each of these interventions add to this benefit? And we just simply don't know the answer to this question. So we've designed a double-blind, randomized, controlled trial where patients are going to receive the wound soaker, but they're going to be allocated to either receiving saline or placebo in one arm versus actually receiving the anesthetic in the other arm. And we won't know, the study team won't know whether they've got the real drug or the placebo. The patient won't know. And this is the way we're going to find out how much does each of these interventions matter.
Well, that's a great study, Mike, and I can't wait to hear how that's going to turn out. Double-blind randomized trials are the best way to look at this, and it's really going to be important to determine how each of these interventions are helping our patients use less opiate medications.
Thank you.
Thanks for tuning in, guys, and if you want any more information, please visit our website at the Colorado Fetal Care Center as we continue to improve care for our patients.